I'm going to talk about enhanced recovery after surgeries and specifically the implementation in urology. I chose this topic because of my experience in medical school, where I was first introduced to successful integrated ERAS, or enhanced recovery after surgery pathways. Since I've been in medical school and residency, I've actually heard a lot of common misconceptions about ERAS, and so I thought I would start by kind of going over the basics and what ERAS is and what it's not. So what is ERAS? ERAS is a series of evidence-based components in the perioperative period that are combined into a type of standardized pathways. There are two general categories of included components. The first is best practice guideline. Examples of that are VTE prophylaxis, pre-op medical medical optimization, such as correcting anemia, and the choice of preoperative antibiotic prophylaxis. The other side, which is what people more typically think of as ERAS, are the aspects that encourage the maintenance of normal physiology during the perioperative period. For example, things like reducing preoperative fasting when it's unnecessary, omitting NG tube use when it's unnecessary, and the implementation of early enteral feeding. The overall goal of ERAS pathways are to encourage a holistic approach to surgery and also create a smoother, less fractionated surgical experience for the patient, which is in theory supposed to enhance their recovery. The structure of the clinical pathway that is made helps to ensure the consistent implementation of the recommendations that are included. Just a few words addressing clinical pathways, which one example of a clinical pathway is ERAS, although there's lots of others. Some people kind of view these as a strict protocol that needs to be followed, and this is actually not what clinical pathways are. And in fact, it's expected that many patients will not continue to follow the pathway at points and will kind of come and go on the pathway as is clinically indicated. For an example, in a recent article in the European Journal of Urology that describes ERAS implementation in radical cystectomy, the authors reported that 16% of their patients had NG tubes, 14% of their patients had bowel prep, and 20% did not receive preoperative carbohydrate drinks, which were all components of their pathway, but for whatever clinical reason, these patients did not adhere to the pathway. The goal of the clinical pathway is to identify best practices for most patients most of the time in a patient with similar conditions. And then the ultimate goal is to reduce variability in clinical practice when it's feasible. And that is variability being defined as patients with a similar clinical condition receiving different care. So to go through the overview of the ERAS components, ERAS pathways are broken down into three different areas: preoperative, intraoperative, and postoperative. Some examples of preoperative components are multimodal analgesia, preoperative alvimipan. Intraoperative components are standardized fluid management, standardized blood transfusion protocols, and intraoperative pain control that is also standardized. Postoperative components include reduction of postoperative opioid use, early ambulation, and early return of diet. ERAS pathways were originally developed in the 1990s in colorectal surgery and has since been implemented in multiple different fields, including urology. Although urology tends to have a lower implementation of the ERAS pathways than other fields. In urology, EROS pathways are typically applied to radical cystectomy with urinary diversion. This is likely due to the complex nature of the procedure, the fact that it has a bowel anastomosis, and which increases the incidence of post-op ileus, and the extensive post-op recovery that cystectomy patients undergo, which in turn would show the most dramatic changes in outcomes. But regardless of that, ERAS can be applied to all urologic surgeries, including nephrectomies and prostatectomies that also can commonly result in ileus. And the idea of just promoting perioperative homeostasis and a smoother surgical experience can obviously be applied to any field and surgery. The remainder of the presentation will mostly refer to ERAS in radical cystectomy, but again, this can be applied to any type of urologic surgery. The ERAS Society was developed in the early 2000s to provide guidelines for individual surgeries, but ERAS protocols and pathways are developed in each individual institution and vary significantly between institutions. Here, the ERAS Society recommendations are stated, and this is specifically for radical cystectomy with urinary diversion. Although note that there are some components that are highlighted in gray that are controversial in radical cystectomy, and they also omit certain components that are typically included, such as alvimipan and the use of urinary stents. Briefly, to go over the components of ERAS in the preoperative setting: counseling and education, medical optimization, the omission of bowel prep, carbohydrate loading, preoperative fasting, anesthetics, preoperative alvimipan are also key components. Intraoperatively, antibiotic and skin prep, VT prophylaxis, standardized anesthetic protocols within the during the operation, epidural anesthesia, fluid management, body temperature management, all of these are key components, as well as minimally invasive approach when it's feasible, the lack of NG tube, the lack of surgical drains, and the placement of urinary stents. And the majority of the postoperative care actually focuses on the postoperative care, including ileus prevention, which is kind of one of the main points that helps reduce length of stay and improve recovery. Nausea and vomit prevention, early mobilization, early oral diet, and ERAS audit. So I'm just going to next highlight some of the key aspects that help maintain normal physiology related to bowel function and present some evidence behind them. For time, due to time constraints, obviously I can't touch on all of the important aspects, but preoperative alvimipan is one of the things in ERAS that has the strongest evidence and the most dramatic effects. It has been well established in both GI surgery and has been studied in radical cystectomy. Alvimipan is a peripherally active mu opioid receptor antagonist that prevents the opioid effect in the gut. So it's administered preoperatively before patients get opioids. A multi-center randomized controlled trial in radical cystectomy patients concluded that alvimipan reduced time to first bowel movement, resulted in shorter length of stay, and resulted in lower postoperative ileus-related morbidity. They also showed similar outcomes when compared to placebo. Yes?
I think an important point to mention about that is that trial excluded patients who had an epidural. So there's not data for using alvimipan along with an epidural, which is something that does happen, that we do here sometimes.
Yeah.
There's not data to support.
Yeah, and they did, it was pretty defined, and there obviously still needs to be a lot more research, but moving on to the next aspect that I chose to discuss, postoperative gum chewing. It's been shown to improve postoperative GI function. The mechanism is thought to be primarily mediated by the stimulation of the cephalic vagal reflex, but also secondary evidence have shown that osmotic laxative effects, and there's actually anxiolytic properties associated with gum chewing in both humans and animal models. A meta-analysis in GI surgery, which included radical cystectomies, identified 7 randomized controlled trials that addressed gum chewing, although it was difficult to create a placebo for this, obviously. But they did find that gum chewing resulted in shorter time to first flatus and bowel movement with similar, although they didn't find differences length of stay. And as I mentioned, limited by the lack of placebo. Early enteral feeding is defined as the initiation of food within 24 hours postoperatively versus the traditional approach, which includes a period of nothing by mouth for the first 24 hours. Evidence in animals and humans suggests that early starvation can be detrimental to wound healing, muscle function, and insulin resistance. A meta-analysis in GI surgery identified 13 randomized controlled trials revealing similar rates of dehiscence, similar rates of pneumonia, and actually identified reduced mortality. The one thing they did identify was an increased risk of vomiting, and that suggests that there are no clear benefits to maintaining patients' NPO, but that feeding should be in combination with medications such as Reglan that have been shown to reduce post-op nausea and vomiting. And in fact, Cochrane Review in 2018 reports that shorter lengths of stay in early feeding and no clear benefits to a period of NPO, although they do conclude also that there needs to be more evidence to make broad generalizations. In regards to the type and choice of diet, hasn't been much evidence or studies comparing these, although speaking to colleagues in our general surgery department, they are tending to, in many cases, start with regular diets in patients without anastomoses and will start on clears and then self-regulated regular diets or low fiber diets starting the first postoperative day. And that's in comparison to starting with SIPs, clears, or self-regulated diet. But only a few small randomized controlled trials have been done, but they haven't found any significant differences in ileus or complications between solids and liquids. Obviously, more research should be done in this area. So overall, ERAS pathways in general and the individual components have been shown to decrease morbidity, mortality, hospital length of stay, reduces variability in care, and overall hospital resource utilization. It's difficult to study these on a large scale because of the differences in standardized pathways from institution to institution. But there is strong evidence, and much more than what I've discussed today, that encourages these type of physiologic implementations. So in conclusion, ERAS is a series of individual evidence-based components that are combined into a standardized perioperative pathway with a goal to improve recovery by maintaining normal physiology and create a smoother surgical experience. And the creation of a pathway helps to consistently implement these recommendations. Complete adherence to the pathway is not expected and often is not actually done, including reasons could include if someone has an allergy to a medication, they're not administered it, or if the cutoff for a blood transfusion is 7.0, but they're hemodynamically unstable and their hemoglobin is 7.1, that indicates that they should get a blood transfusion. Each ERAS protocol or pathway is adapted by an individual institution and is agreed upon by the specific local community. In urology, mostly we apply ERAS to cystectomy, but again, it can be applied to and should be applied to all surgeries. And there is strong evidence supporting the key components of ERAS pathways, though it can be difficult to study on a whole scale. Questions?
One of the things we've noticed in urology and in many of the other fields across the health system is even though the educational documents have been created for patients and there have been order sets created and there's been data to support ERAS, uptake hasn't been very strong.
Yeah.
What do you think is behind that?
There's a lot of things that, you know, I think there's a lot of misconceptions about what ERAS is. You know, it is kind of unclear why specifically in urology it hasn't really filtered in compared to other, like colorectal surgery. That so I don't know. It's hard to say why specifically in urology. Do you have any other?